So this is just a case summary of the presentation, and then Dr. Miba will take on the literature review. So I'm presenting JB, male, 8 years old, a case of parahemophilia, first presented to the University Teaching Hospital in 2020 at the age of, came in with a history of a fall and sustained the injury was sutured, dressed, and was mom noticed that the bleeding started again at the injury site and went back to a local clinic. Sutures were revised, hemostasis was achieved, and then patient was sent home. And later the same night, started bleeding again, and then for further evaluation and management. So when taking the history, mother did give a positive history of easy bruising and bleeding under the skin, and also history of recurrent epistaxis. Otherwise, birth history was unremarkable with no prolonged bleeding from the umbilicus. And then in terms of immunization, the patient was up to date. Give a history of epistaxis herself and also her brother. With developmental history, there was no notable developmental delays. And at that point, an impression of bleeding disorder was made with and then later the same year, in August, he presented with out. So due to some financial restraints, we were unable to do factor 8 and factor 9. So it was presumptively started on factor 8 through 2023, where we managed to get the test. The following slides will just show what the results and the findings were. So in 2021, he presented with elbow hemarthrosis. In October 2023, presented with left shoulder hematoma of the left scapular region. And then April, July had left elbow swelling. October 2024 had bilateral. March this year had left elbow hemarthrosis, and this current admission has left elbow hemarthrosis. So time and has been 7.6, red cell count of 4.8, the hemoglobin is at 12.5, sorry. MCV is at 74, MCH is at 25.8, MCHC is at 34.8, and then red cell distribution width is at 13.3%, with a platelet count of 361 by 10 to the power 9. So these were the results and the findings. So the clotting profile was done, and of note was that APTT was raised, PT was raised as well. That's prothrombin time, and INR was raised as well. Mixing studies were done as well. Noted some elevations, and then factor 8 ASL results showed and which was on the hand, nimicizumab was started, and then factor 9 was also at 70%. Factor 5 was done, following the findings of factor 8 and factor 9, which was at 51%, which wasn't significantly low. So factor 10 and von Willebrand factor antigen was also done, and factor 11 activity as well. And these were the percentages and the findings. So in terms of the cost of treatment, patient was started on factor 8 replacement therapy, actively awaiting factor 8 and factor 9 is.
Hi, sorry, I don't know if it's just me, but your sound
Still
isn't
20.
good. Is it just me, or is it
No,
No,
the sound is not
quite
very
patchy.
good. We are all, I think I'm also experiencing sound problems.
Were able to afford tests.
Shirley? I wonder if you should exit and come back in again.
8 and factor 9 were out. Patient was started on emicizumab monthly, and then
Might not be able to hear us. Shirley, can you hear us?
Yeah, I think it was very difficult
Yes, I
to
can hear
hear because of the internet. So I don't know if you want to start again, or
I don't think
start
Shirley needs to
it's a
start
bit.
again. We kind of got the gist because you're reading to the slides, which were very helpful. I think if you
Oh,
go
okay.
back to the bit where you're discussing the 8th and, that you did the factor 8 and factor 9 levels, you've sent it off. Once you've sent it off, then you started the emicizumab, and then you mentioned that, there have been more recent admissions where you've been treating with FFP. I think if you go back to that slide, I'm not sure whether the slides are the reason why we can't hear you very well. So, but we can, because at the moment there is no slides on this on the screen.
Okay, maybe we can do that.
Yeah, that. Yeah,
Are you able to hear me
definitely
now?
can hear you now. Thank you.
Okay. So, is this a slide you're talking about? That
Yeah, the sound's still a bit hit and miss. So if you go to the next one. And then the following one.
So this is the last one.
Okay, cool. In that case, I would suggest that you stop the video altogether. Then your sound will improve. As in, stop sharing, not video. I know your video is stopped anyway.
Okay.
Shirley, do you want to, Samas, are you here?
Yes,
Hi,
I'm here.
Shirley.
Yeah, okay, sorry. Can you sorry, you probably want to take over.
No, it's okay. Maybe
this-
Shirley, if you want to just give us a 1 minute just summary of the case, because I think as Varna was saying, your audio is really good without the share screening. So you can leave the sharing. And then we can go through the literature review with the next speaker.
Okay, so our patient is 8 years old, by the name of JB. First came to the University Teaching Hospital at the age of 4 with a history of a fall, and then sustained a laceration on the upper lip. Went to the local clinic where it was sutured, but 2 days later, mom noticed that the bleeding continued. So she went back and the were revised. And then the very evening, started bleeding again. So then mom decided to bring the patient back to the hospital and was referred to the teaching hospital for further evaluation. And at that point, the full blood count was essentially normal, but we're unable to do the factor assays due to restraints in terms of finances. So patient was then managed as a hemophilia A patient and started on factor 8 presumptively. Has had about 10 admissions since that age, of which some were bleeds in the joints, had a calf bleed as well, and then also had a cheek bleed. So when we managed to get the results for the factor, which were normal essentially, that's factor 8 and factor 9, factor 11 and factor 10 activity, and also von Willebrand's factor assay, antigen, sorry. So on the admissions, he has received fresh frozen plasma. Currently, he's stable, and that's basically just a quick.
Amazing. Thank you very much. Thank you, Charlie. That was excellent. Very interesting case. So I think there's somebody else presenting a literature review, isn't it?
So Dr. Mundo will take up the literature review.
Good afternoon. Can people hear me?
Yes, good
Yeah,
afternoon.
good afternoon.
Yes, this is Helen. I'll be giving a literature review of parahemophilia, which is factor 5 deficiency. Okay, so that's the outline of the presentation. We'll introduce, I'll go through the pathophysiology, classification, clinical, and then we'll conclude and attach the references. So just to introduce, parahemophilia is a rare autosomal recessive bleeding disorder. So like I was saying, parahemophilia is a rare autosomal recessive bleeding disorder caused by deficiency or dysfunction of coagulation factor 5. So in terms of prevalence, it's extremely rare with an estimated incidence of 1 in 1 million individuals. So this condition was first described by a Norwegian doctor, Dr. Paul Oren, in 1947, who distinguished this type of factor deficiency from the classic factor 8 and factor 9 deficiencies. So it's important to understand that parahemophilia is a rare disorder and therefore needs to be investigated because it's got potentials of severe bleeding complications, particularly in the pediatric population. So just to run through a brief overview of the pathophysiology. So factor 5 is a crucial cofactor in the coagulation cascade. It facilitates the conversion of prothrombin prothrombin to thrombin in the presence of factor 10A.
Helen, your sound's gone again. Helen? Helen? Helen?
There's a very bad echo. There's a very bad echo. We can't hear anything.
Phospholipids. So
Helen?
it exists. Hello?
Helen?
Yes, I can get you. Can you get me?
Let me share the
We
screen.
are getting them, but they're not getting.
Just let me share the screen on your behalf. We see if that would be better.
Oh, I can get you.
Yeah, we can't get you.
Hello?
Okay, let me just share the screen.
Okay. Am I audible now?
Yeah, we can hear you, definitely.
Yeah, great. Okay, can I start? Can I start all over again, or should I continue from the pathophysiology?
The
No,
pathophysiology,
start all
please.
over. I didn't hear a thing from the time you started. There was a lot of echo.
Ah, all right. So then in that case, I don't know if that's a suggestion for me to start again. I can start all over again. So we can start from the introduction. So I was saying parahemophilia is a rare autosomal recessive bleeding disorder, which is caused by this deficiency or dysfunction in coagulation factor 5. So this condition is extremely rare with an estimated incidence of 1 in 1 million individuals. So this disorder was first described in 1947 by Paul Oren, a doctor, that first distinguished the class hemophilia A and B from this deficiency in clotting factor 5, which is called parahemophilia. So the importance of this is that because this condition is more rare, very rare compared to the clotting factors, factor 8 and 9, as well as 11 that we have, it's important to investigate for it as it presents with severe bleeding complications, especially in children. So we can now go to the pathophysiology. So the role of factor 5. So it's a crucial cofactor in the coagulation cascade as it facilitates the conversion of prothrombin to thrombin in the presence of factor 10A, calcium and phospholipids. So it exists both in plasma and platelets, and activated factor 5A accelerates thrombin generation. So now, how does this deficiency in factor 5 come about? So it's by a mutation in factor 5 gene, which is found on the chromosome 1q24.2. So this leads to a reduction or dysfunction of factor 5. And when this is reduced, when this factor is reduced or its dysfunction, it results in impaired thrombin generation, which in turn prolongs the clotting time as well as increasing the bleeding risk. So classification, it can be inherited or acquired. So the inherited is the one that we've talked about. It's inherited in the autosomal recessive pattern. So meaning that a patient has to be homozygous for the condition, though heterozygous individuals do exist, but they don't present with a condition. So acquired, so this is less common. It's a less common form compared to the inherited. And this comes about when the inhibitors are formed, when the factor V inhibitors formed. So the risk for these inhibitors to be formed, if there are certain antibodies which come about when a patient is taking certain antibiotics,
Hiya, the sound is gone. Hello?
I think, yeah, obviously they're having some difficulties with the audio. Shirley and Helen, I don't know if you can hear us.
I can't hear the presenter's voice. It's on.
Yeah.
Yeah.
beta-lactams, if there are conditions such as malignancies, liver diseases, autoimmune disorders, just to mention a few. There's our next slide. Am I still presenting? I figured.
Yes,
Can you hear me now?
Yes, we can.
Yeah.
Yes.
I'm muted now.
I'm still muted.
Helen, we
Hello?
can hear you now. Carry on. We can hear you.
Okay. So I was talking about the different classifications. So the second type. Hello? Hello?
Hello.
Hi.
Hello.
Yeah, we can hear you.
You are
All
clear
right,
now.
great.
When you keep going and coming,
Yeah.
it's really making it difficult to follow.
Okay, so we are now presenting from the phone. I'm using the phone. I don't know if this will make things better.
We
I
can
think-
definitely hear you better now.
Yeah,
Let's
just
see how it goes.
I think it will be better. Great.
All right, so the other classification is according to the type. There's type 1 and type 2. So in type 1, there's quantitative deficiency of factor V. In this type, there's there are low amounts of factor V levels. And then the second type is qualitative defect, where the numbers of factor V, if we can call it numbers, they are okay, but they're dysfunction. And then there's another one that classifies it according to severity. So normal factor V in the body should be about 70 to 120%. But in people that have got parahemophilia, you find that in mild cases, this factor V is between 5 to 70%. In moderate cases, it's 1 to 5%, and in severe cases, it's less than 1%. So we can move to the clinical presentation. Okay, so symptoms actually vary, but based on the factor V activity levels. So commonly we find that these children who present with easy bruising, epistaxis, mucosal bleeding, both in the mouth, maybe in the GIT. And then there are those severe presentations where children present with hematolosis, intracranial hemorrhages, or postoperative bleeding. Patients that are heterozygous for the condition, like I said, usually are symptomatic. So just to consider some groups like the neonates, these may present with bleeding after circumcision for the males, and also prolonged bleeding from the umbilical stump. So in these age groups, you find that there's delayed diagnosis because this condition is rare, and as you can see, the presentations are variable. So compared to the classic hemophilia, A and B, parahemophilia affects both genders equally because it's an autosomal recessive disorder. We can move to the next. So diagnosis or evaluation. So it involves a detailed history. So in the family history, we expect that both males and females could be equally affected, and it's most common in consanguinity groups. And then we also need to ask for bleeding episodes in family members, apart from the patient that presents. So for the physical exams, there are signs of bruising, petechia, joint deformations, or that's in severe cases. So some tests that can be done, the laboratory tests. So like we saw from the case, prothrombin time, both prothrombin time and activated partial thromboplastin time are elevated. And then factor V assays confirm the deficiency. So less than 20% of if someone has got factor V assays of less than 20%, you find that this is when they're symptomatic. But for those that are above 20, they could be asymptomatic. So there's also a role for genetic testing, which identifies factor V gene mutations for a definitive diagnosis. Differentials include combined factor V and VIII deficiencies, von Willebrand disease, and other coagulopathies. Okay, so management. So the general principles of managing these patients. So we need to take note that there is no specific factor V concentrate that's available at the moment. So the treatment focuses on replacing factor V and controlling the bleeding. And it also involves multidisciplinary approach, so that involves hematologists, pediatricians, and genetic counselors. So in our setting, we are using a fresh frozen plasma, which is being given at 10 to 20 mL per kg at the time that the patient presents with an acute bleed. And then platelet transfusion is considered in severe cases, as platelets contain a function of factor V. Desmopressin may be used in mild cases to enhance endogenous release. For mucosal bleeds, we are using tranexamic acid. So for surgical and prophylactic management, so we need to make sure that FFPs are given before a patient undergoes an operation, if at all they've got this deficiency, if they've got parahemophilia. We can move to the next one. So look at the complications and prognosis. So complications include intracranial hemorrhages, joint damages, and then there's also transfusion-related risks, such as the volume overload, and then allergic reactions and transfusion-transmitted infections, which have now become rare. Prognosis, so this varies depending on the severity. So mild cases may lead to normal lives with normal interventions. Severe cases, these require lifelong monitoring and management. And also we need to counsel families on the chances of them. Since this is an autosomal recessive, chances of them having children with a similar condition. So special considerations, of course, in the pediatric age group. So we need to note that there are challenges in diagnosis, and this leads to delayed treatment because the way they present is non-specific to. You find that if for mild cases, moderate cases, the presentation is really non-specific. So this causes delayed diagnosis and therefore delayed management. So neonates are at risk of severe bleeding, that is especially after invasive procedures. So other management adjustments, we could lower FFP volumes to avoid fluid overload in infants especially. We need close monitoring during growth spurts because in this age group, they're prone to trauma as they're involved in activities that can predispose them to such. And then parents also need psychosocial support in educating them about the condition, as it is a rare form. So when we talk about things that are currently happening, so gene therapy is being considered. So this will lead to early detection. It's in the early stages. They are targeting the correction of factor V gene correction. And also because we don't have factor V, an isolated concentrate of factor V, this is what they are also trying to work on, so that we could have just a factor V concentrate that we could use to replace like we do in hemophilia A and B. So far in diagnostic improvements, there is the next generation sequencing for rapid factor V mutation identification. But this is currently not available in our setting. Yes, and also because this condition is very rare, we need some increasing awareness because there are these children that go undiagnosed. If we don't find factor 8, factor 9, factor 11 deficiencies, then you find that these conditions just go undiagnosed. So we need some form of increasing awareness. So in summary, parahemophilia is a rare but significant bleeding disorder due to the factor V deficiency. And diagnosis requires a very high index of suspicion because we said it's very rare. So clinicians need to have a high index of suspicion. And then management currently is relying on FFPs and supportive care. So take-home messages: early recognition and tailored management are critical, especially with pediatric patients, to prevent life-threatening complications. So these were my references. Thank you.
Thank you so much, Helen. Thank you. That was excellent and much better audio. Thank you for switching to your phone. Amazing, interesting case. Well done. I think I had just one comment and perhaps I missed it in your initial slides for Shirley's slides. So did you have access to just a standard PT APTT at the initial stages when he was coming in with all those bleeds? Because perhaps that would have given you a clue, as you mentioned in your literature review. Both PT and APTT would have been prolonged, and maybe that would have pointed you earlier to think about factor V and maybe perhaps factor 10.
Oh, yes, we had results that showed increased prolonged prothrombin time and activated partial thromboplastin time. So that was done in our case study.
Okay, but then the factor 5 assay came later for financial reasons. Maybe parents couldn't afford it initially. Is that why?
Yes, that one came at least 2 years after the initial visit. Yes.
Okay, perfect. And then my other question was about siblings. You've already mentioned autosomal recessive inheritance. Does this patient have any siblings, and have they been tested as well?
Yes, the patient has siblings, but they're yet to be tested. So far, none have presented with any symptoms suggestive of bleeding disorder.
Amazing. No, thank you very much for your presentation. I think we can open to anybody in the audience. Anybody has any questions or comments? Sabana, yep, go ahead.
Yeah, thank you, Sama. My question is, I mean, obviously, when you did the child's factor levels, the factor 5 wasn't low, and that was possibly because they've had some FFP before you did the test. So my question, I guess, is how long? So I have 3 questions. One is, how long after the FFP? You may not know this answer, but I'm just asking anyway. Did this test get done? Number 2 is the child, what other kind of long-term problems with the intra-articular bleeding? Have they got long-term contracture and damage to the joint? And my third question is, how did you come to the diagnosis of factor 5 deficiency if you didn't get the levels, or as a matter of fact, any levels if they were done after treatment?
So we had factor 5 levels, they were at 50%. And how long after? It was about 2 months after the last FFPs were given. That's when the factor 5 levels were done.
So it is unlikely to be factor 5 deficiency then, if it's, factor 5 level of 50% to me does not look like deficiency. Sama, what do you think?
Well, I think for us, we use different units, but I think it might be that in the context of prolongation of both PT and APTT and normal other factors of intrinsic and extrinsic pathway, having almost a borderline result of factor 5, that might have been what made this diagnosis more likely for the team. I can see APTT mixing studies. So was there full correction on the mixing studies? Let me just see. I don't think I can see it on the screen. PT prolonged, APTT is prolonged, slightly INR, APTT mixing studies. So when the mixing studies, was there full correction of the PT and APTT? Maybe was your thinking, but because the factor 10 activity is clearly not low, 78%. We've got normal vulnerable antigen, 11, 8, and 9 are both all of them are very high. I think a borderline factor 5 possibly is what made this the most likely diagnosis here in the context of prolongation of both PT and APTT. So 50% is just on the cusp of just about.
Yeah, but you wouldn't expect somebody to have such severe hematorosis and intramuscular bleeding if they've got, if they've got such high levels. I mean, I don't know if we've got the right, unless, I don't know, because, sorry, Helen, if you go back to your previous slide, you've explained, or maybe not the previous, the subsequent slide. I think there's one slide where you gave a mild, moderate, severe definition. because symptomatically the patient is extremely severe, right? And
Yeah.
you would expect it to be, quite low levels. So I wonder whether this could be I don't know. I'm not sure we are 100% certain that this is factor five, although, yeah, see if you look at that.
Mm.
If you're saying mild deficiencies where this patient's levels are sitting, then you wouldn't expect this severe degree of spontaneous hematorosis, would you?
Yes, you're right. Because he's had multiple hematologic episodes and many different occasions throughout his timeline. But the thing that would help here, and I don't know about availability, would be genetic testing.
And I have another question is, does he respond to any of his treatments? So if you say give him, I'm presuming he didn't respond to emicizumab or factor. I mean, I don't think he received factor VIII concentrates, but does he respond to the factor V? Sorry, FFP.
Hello.
Yes.
Yes,
So surprisingly, this patient actually responded first of all to the factor H that was given, responded to emicizumab. It was only changed because now factor V levels were done and was borderline, was a mild parahemophilia. So even the FFPs actually helped the patient.
And sorry, go on,
So,
whoever's talking.
yeah, yeah. So I think one of the challenges with experience and has been shown is, of course, doing the investigations at different time points. If you notice for example, the clotting profile, the APT done at a different time, then the factors done at a different time. And I think this is actually a good case for us to now try and revisit and also tally it carefully with the symptomatology. I think I'd attempted to share that slide. So maybe Helen and team, it would be nice to see, oh, wait, I'm back the same place. See if we can properly map the symptoms to the time of presentation for certain things and the treatments. Why do I keep coming to the same slide? Okay, yeah. So I think my thoughts were, I don't know, Subhana and Sama, concerning the qualitative defect. Like, how easy is it to determine that this is more qualitative than quantitative? Maybe also aside from the genetic testing as well, which may be of help as well.
so the assays are quantitative.
Yeah.
So yeah, so what you've got is a quantitative assay to see how much of the factor V is on board. It's an immunoassay, but I think that I know it's difficult, but I think from my mind, the best, most straightforward thing is to do genetic testing to identify the genetic mutation, and then based on that decide. But I don't know if there is an actual qualitative assay for factor V, and whether
Yeah,
that's available
I'm
anywhere.
not sure there is actually. I'm not aware that there is. And
But yeah,
sorry.
no, go ahead, Saban.
No, I was going to say that, it's because the patient has very prolonged APTT, we know that at least we know that it's and it's a male patient. But what I mean, I'm not sure about the PT being mildly prolonged. It's not as prolonged as the APTT. And I guess that's why you're kind of thinking about, because the PT was also prolonged, you're probably looking at factor V more than anything else. But what is also surprising is that not, very specific things like emicizumab, which will only act in factor A deficiencies, actually also respond, this patient has responded. So I mean, the only other thing one could do if you can't do genomics would be to see whether you could do some family history taking. I know that there is history of easy bleeding in the mother, I believe. So if it's in the mother, I guess it's difficult to interpret often with maternal, it's a female history of bleeding because women obviously bleed every month and people can have heavy menstrual period for other reasons other than sort of hemophilia. So if there is a history of somebody who's within the family, clearly if this is factor 5, then it'll autosomal recessive, which means that both genders can have it. So if there are other symptomatic patients, and if the patient would be willing to, I know all of this is out of pocket, so if it's possible to test some of these individuals, then you can get a rough idea of what you're dealing with. But again, I think it's going to be very difficult to unravel unless you give the patient a good 3 or 4 months or 2 or 3 months, if you can. I mean, clearly you still did the blood test 2 months after, didn't you? So as Thilo says, that if you've done a blood test, I mean, that's maybe one little bit of detective work that has to be done is, did the patient really not receive anything in the 2 months preceding this factor assay? Because sometimes people can go elsewhere to receive, or they, it might have not been documented or something. I don't know. I mean, obviously I don't work in your setting, but just to see if, accidentally some FFP has been administered unknown to the treating team. I don't know other than that if anyone else has any ideas.
I was just wondering about factor 2, Thilo. Did that get tested as well? Because that gives you a very similar picture of prolongation of both PT and APTT.
I don't think so, but let me just. No, it wasn't done, Helen, right? Yeah, I don't think it was done.
No, it wasn't done.
Maybe to Subarna's point, because factor 5 is not that deficient, just borderline, perhaps a factor 2 would add to the picture, add some light, because can also give you a similar features of both PT and APTT prolongation. And the other thing I was wondering about is also fibrinogen level. Has that been tested? Because again, similarly, it could give you both PT, APTT, and in some cases can be quite severe. A fibrinogen assay.
Yeah, I think that's a fair point. I think factor 2, so prothrombin levels and fibrinogen levels might be helpful. The other thing would be, I mean, obviously the question for the MDT is really A, diagnostic, B, how do you manage this patient? I mean, obviously any of these slightly rarer conditions you can't really give anything specific other than FFP. And presumably in your setting, I mean, the only other thing, Sama, is how about tranexamic acid? Is that something that can be given to this patient on a day-to-day basis, or could it be reserved for when he is had minor injuries or something? I'm just thinking whether that could be something that could be thought about in the absence of any FFP. Yeah,
I mean, it could be used for any of those bleeding disorders, the rare ones, because
exactly,
it does help with hemostasis, but mostly in minor bleeding or in somebody in an acute presentation, initial phases, or maybe in preparation for minor surgery.
Exactly. So I think in terms,
sounds like he's severe, isn't it? Very severe.
Very severe, yeah. So, and there is a mismatch between the levels and the degree of severity. And I don't think, I mean, I know Thilo quite rightly thinks that this could be a qualitative, deficiency of factor 5 rather than a quantitative deficiency. But without genetics, I don't think we can unravel that. I'm still going to question slightly, given how rare it is to have this. I mean, to have a qualitative factor 5 deficiency, that it's worth revisiting whether what you're dealing with is, it's a male patient, is it straightforward factor 8 or factor 9 deficiency that you're dealing with, and actually it can't, I don't suppose it could, and actually the reason why it's so high is because inadvertently some treatment has been given. before you took the blood test in April 23. And so I guess in that sense, some of that investigations will need to. I mean, you guys look after a lot of bleeding hemophilia patients, and I'm presuming that there will be some, similarity in their presentation. Does this child look very different or very similar to your severe hemophilia patients?
Helen?
Hi, Tilo.
Hello.
So I'm trying to remember Joseph. So I think for the severe hemophilia patients, there is a bit of difference. He doesn't present as the other severe ones that we get in, especially the severe ones, we usually come in with the muscle bleeds in addition to the knee hemathroses. So Joseph, if I remember correctly, usually presents with the elbow hemathroses the past few admissions. Yeah, so if you look at in about 2 years ago when he presented, he only had one hematoma in the scapula, but all of the other ones have been sort of elbow, shoulder. If I can remember correctly, I don't think of any knee, or any other muscle hemathroses, if we're to classify him in sort of a hemophilia severe presentation. So his presentation is different from the others.
Yeah, that's interesting, I guess. Yeah.
Very interesting and very, very, very rare. So in all of
Very
the
rare,
hemophilia
very
patients
rare.
we look after here, and we're one of the biggest centers, we don't have a single severe factor 5 patient, factor 5 deficiency. And it's even more rare in an African setting in terms of inheritance. But maybe complete the assessment by checking other factors like factor 2 and a fibrinogen level, and see if there's anything else that is maybe missing from the picture that would influence treatment. Although, as already had been said, treatment would probably be along the same lines if we're dealing with a condition that does not have a concentrate, especially in this setting. But yes, I would definitely recommend checking the factor 2 fibrinogen, and see how he gets on. And perhaps even repeat that 5. Repeat it maybe outside of a treatment day. How often are you giving the FFP now? Is it twice a week?
I imagine they're getting it only when they're bleeding, right?
Mostly, yeah. But Helen
Yes.
can.
So he's only getting it when he has the bleeds.
Yeah, so you might have an opportunity to maybe just bring him over one day when he is, if possible, to do those tests outside of a bleeding window, which I can understand might be quite challenging from a logistical point of view. I mean, and then we could discuss this when we have one of our colleagues with, who might, one of our hemophilia colleagues who I think is coming with us to Zambia.
Yeah,
So
it'll be nice if you can try and have it.
yeah, we could
Okay.
discuss this case again. Yeah.
Yeah.